I will introduce the first speaker, Dr. Panicos Shangaris. I hope I said that right. Good. Class of 2005 is going to speak to us about crack in the creation, prenatal therapy for congenital blood disorders. Dr. Shangaris, having left here, went to UCL, University College London. He got a master's from there. He received a distinction in fetal medicine and prenatal genetics, and then he did a PhD there also. He works also at King's College London as a clinical lecturer, and he is now the clinical senior lecturer there and a consultant in maternal and fetal medicine. Dr. Shangaris, thank you.
Good morning, everyone, and thank you for the introduction, and thank you for inviting me to present my work at King's College Hospital and King's College London. So I'm going to talk about the potential of prenatal therapy for treating congenital blood disorders, and I'm going to focus on sickle cell disease as a model of disease. And sickle cell disease is the most common monogenic blood disorder, and it affects about 3,000 newborns every year with sickle cell disease. In the UK, we have about 18,000 patients affected by sickle cell disease, and at King's alone, we care for 4,000. So 1/4 of the sickle cell patients in the UK are cared by King's College Hospital. Now, sickle cell disease basically affects the whole body, and because of the sickle shape of the red blood cells, it causes anemia, sickle cell crisis, which are basically painful crises. Most of the patients with sickle cell disease are well known to their nearest A&E department, and the only curative treatment at the moment is stem cell transplantation or gene therapy, which I will mention in a few slides. So as I said before, it causes problems in the whole body, and most of the sickle cell disease patients their quality of life is quite bad. So what is gene therapy? Gene therapy is defined as the treatment of disease by transfer of genetic material into cells of patients. Now, the current treatment for sickle cell disease is mainly palliative care with regular blood transfusion or disease-modifying drugs like hydroxyurea. Hematopoietic stem cell transplantation is only available to about 1/3 of the patients because they need to have an HLA-matched donor. And I'm not sure if you heard the news about 2 years ago, the FDA has approved 2 gene therapy products for an ex vivo gene therapy for sickle cell disease, the Casgevy and the Lyfgenia. And what they do, the Casgevy is basically reactivating the fetal hemoglobin, and the Lyfgenia is basically replacing the affected gene with a healthy one. There are a few sickle cell and hemoglobinopathy trials in the world, and a lot of companies are investing a lot of money on this. The most popular is Bluebird Bio, and basically the technology is advancing. This is the journey of a patient, or let's say a woman, when they initially get pregnant. That's in the NHS. So what happens once they get pregnant? They will do a pregnancy test, and it will be positive, and they will go to the website of their nearest hospital. They will register for maternity care, and they will be asked to go to the midwife for the booking visit, which happens around this time. The midwife will ask them questions, and they will try to classify the pregnancy as high risk or low risk. And at that point, they will basically pick up if both parents are carriers for any hemoglobinopathy, such as sickle cell disease, and they will be referred to The fetal medicine unit, after counseling for if both of them are carriers, they will be referred to the fetal medicine unit for an invasive testing in order to identify an affected fetus. So what are the options? At the moment, what happens is if a fetus is affected by sickle cell disease, we basically offer a termination of pregnancy, which can be done at any point, or we let the parents know, and then they are giving birth to an affected fetus with the hope of a postnatal treatment. But what we are proposing and working on is on the prenatal gene therapy approach, which is basically an in vivo approach in order to, and we are trying to correct the disease in utero. And the technology at the moment allows us to identify an affected fetus from 10 weeks onwards by using non-invasive prenatal testing. And the idea is to give to the patients a few weeks time to think about the potential of a prenatal gene therapy. Now, why a prenatal gene therapy? Why not waiting for the baby to be born? The idea is if you offer an early treatment in a fetus, which is about 5 to 6 centimeters long, then the gene therapy product you use is minimal, and also you take advantage of a window of opportunity where the hematopoietic stem cells site in the liver of the fetus, and then you can target the hematopoietic niche before the migration to the bone marrow. In addition, some patients might be considering termination of pregnancy, and when you do the consultation for counseling for a prenatal approach, they might opt for that option rather than terminating the pregnancy. So what are the options for gene therapy? So gene therapy, first of all, you need to take the gene editing tool or gene therapy tool inside the cell. So you need to have the gene therapy tool, which can be an mRNA, for example, and you also need to have a vehicle to transfer the cell. And the options are in the adult, for example, you need to mobilize the hematopoietic stem cells, which are the defective ones, then harvest, correct these hematopoietic stem cells using the gene editing tool, and then expand them, and then give myeloablation to the patient in order to create space, and then transplant back. So this is an autologous approach. And the other approach is to do an in vivo, where you have an off-the-shelf product where, with nanoparticles, for example, where you inject intravenously, and these nanoparticles will have the ability to go to the hematopoietic stem cells and edit or insert the corrected version of the gene. So everything started when I started my PhD at UCL in 2011, where we were trying to study the potential of amniotic fluid stem cells as an autologous source of cells in order to treat congenital blood disorders. And the idea was to take the amniotic fluid stem cells, and we know that they have hematopoietic component or properties, correct them in utero, and then transplant them back to the same fetus before the baby is born. And we did prove that the hematopoietic potential of amniotic fluid is there. They can be transplanted in utero when you do an in utero transplantation in a mouse model of autologous versus allogenic transplantation. And you can use different techniques like intraperitoneal injection or intravenous injection, which was more efficient. And using the intravenous injection, we were able to prove that the engraftment was reaching up to 20%, which is the ideal engraftment you need in order to achieve phenotypic correction. And then the next idea was, why not giving gene therapy directly to the fetus, which basically will remove the need of a high-tech lab to manipulate the cells ex vivo. And this is what we've done. We basically use the lentiviral vector, which carries the corrected beta globin gene, into a mouse model of beta thalassemia. And we were able to show phenotypic correction in the beta thalassemia mouse model, but we were able to also to see that there was side integration to genes were not supposed to have any relation with the beta thalassemia. So we said this is probably not safe, and you will never go through approvals. And then we started working with nanoparticles when I moved to King's, and the idea was there, and also other groups were working on it. So using nanoparticles to direct the gene editing tool to the hematopoietic stem cells in the fetus. So the idea, you have a nanoparticle which carries the mRNA. It is taken up by the cell, and basically, eventually, the base editor or any other editor will go to the nucleus and correct the defect in the sickle cell disease. So, which injection is the best? You can have different types of injection, either intravenous, intraperitoneal, intracranial. You're trying to target any neurological disorders, or also intrahepatic. And we are currently working on the intrahepatic injection using a mouse model of sickle cell disease. There are a lot of groups which have demonstrated that using nanoparticles is an efficient way to target and deliver mRNA to the cells, both in utero and in the adult patient. So what are the challenges? The challenges are which nanoparticles, how we are going to design the nanoparticles to target only the hematopoietic stem cells compared to giving the nanoparticles and let them transfect all the cells. What is the dose? If there is any immune response towards the to the nanoparticles. And also, once we introduce a needle to the amniotic sac, we have 1 in 200 risk of a miscarriage, which is basically another risk which needs to be discussed with the woman, with the pregnant lady. In addition, is there an off-target effect or any off-target risk to the mother? If any of the gene therapy product escapes to the maternal circulation, what is the impact on that? And how do you develop any prenatal or any gene therapy product? You need to first you need to decide your gene editors. Then you have to test them in cell lines which have the same mutation, for example, as the disease you are studying. And also you need to recruit patients with sickle cell disease to test this product there. And then we have the mouse model of sickle cell disease. First, we were able to show that the mouse model of sickle cell disease recapitulates the human disease. So it has splenomegaly, it has anemia, the splenic architecture is disturbed, as you can see here. And then we were able to demonstrate that we can achieve intrahepatic injection into the mouse model of transplantation. And we were able to show that GFP nanoparticles actually go from the fetal liver to the bone marrow. Now, my PhD student, Lisa, is working on the optimization of nanoparticles, and she's testing different formulations in order to basically optimize these nanoparticles to target the hematopoietic stem cells only. And we are now at the process of trying different antibodies in order for the nanoparticles to only target the hematopoietic stem cells compared to all the cells. So she has demonstrated that nanoparticles can transfect different cell lines, and of course the different cell lines respond differently to the actual cells of patients. And as you can see here, these are the peripheral mononuclear cells from patients, and she was able to achieve, for example, transfection efficiency of about 50% when she was using this formulation, where if she's using this formulation, the efficiency was low. And this basically was was demonstrating a different result when she was using the cell lines. And of course, we were also looking at the ethical consideration, because we are talking about delivering a treatment to a fetus who cannot consent because it's inside the mom's tummy. And we wanted to ask for the opinions of stakeholders and carers from patients who look after sickle cell disease patients. So we basically did a promotional video in order to recruit carers and stakeholders, and we collaborated with the Sickle Cell Society in order to do a qualitative study and see what they thought. And this is the video.
Sickle cell disease is a hereditary disorder that affects the structure and shape of the patient's red blood cells. This affects their ability to move through blood vessels and carry oxygen to the body. The condition is caused by a genetic change that results in unusual red cells called sickle cells. It affects approximately 400,000 babies each year worldwide. Sickle cell disease has severe health consequences, including anemia, infections, strokes, and daily pain. If untreated, it can be fatal. Recently, scientists have developed a potential new therapy for treating sickle cell. This therapy would cure the baby whilst it is still in the womb by changing the genes related to the condition. Before seeing use, the procedure will be extensively tested to ensure safety and effectiveness. Doing this also helps understand if there are any side effects. Such a treatment could be offered in outpatient clinics via a single prenatal injection, and would also be affordable in low to middle income countries where most sickle cell disease patients live. We would like to invite patients and families to take part in an interview, which would help us understand any questions and concerns they may have, and if the treatment is something they would consider.
So we basically interviewed about 20 people, and all of them were positive towards a potential prenatal approach, and there were some concerns as well if it was safe, if the treatment will last for the duration of the life of this patient. And of course, if there was any off-target effects which might affect the mother. And we are currently writing up the manuscript and will be published in the next few months. These are my two PhD students who work on the project. Lisa is working on the development of lipid nanoparticles, and Alex in the optimization of the gene editing tools. And all the other students who worked on the project in the last 6 years. And that's it. Thank you very much.